Yeah.
In the metastatic, it's the 522, which is the brings in the gemcitabine carboplatin.
355.
355. That's 355, right? 355.
So 355, KEYNOTE-355 is the first line metastatic. You're just testing me.
Make sure you got your keynotes right.
That's right, get the numbers right. 355, so that's looking at first line, very similar to the Impassion 130 population, looking at first line metastatic triple negative breast cancer, chemotherapy, with or without pembrolizumab, and yes, they have a gem carbo arm, so that'll answer a slightly different
Here's my question about that trial. And so it's physician choice. So the choices are nanoparticle paclitaxel, paclitaxel, or gem carbo.
Right.
So do we know, I don't think we know yet how many are in each arm, right? They're not equally distributed. It could be all paclitaxel for all we know, right? So that's, how's it gonna help us? You know, so the question will be, suppose it's like, you know, because we have nanoparticle paclitaxel. What's the proper partner, I guess is where I'm going with this. We have nanoparticle paclitaxel, clearly benefit, but now we have this trial and it's unrandomized physician choice, whatever they decided to do. So how are we going to fix that? How are we going to decide what we're going to do with that data?
Maybe the point estimates will be the same for all three.
Let us hope.
You know what I mean?
Like when we do the forest plot, they're all the same, and there's enough patients in each, you know, subgroup to be able to make that forest.
Right, and unlikely to be huge differences, probably. You know.
How big was 355? Do you know the size?
I think it's 900.
So it is fairly substantial. All right, so it's
around that. But you're right, it might be that we'll be doing cross-trial comparisons because it's mostly a paclitaxel, not nab-paclitaxel enriched
and
population.
And there'll be very much gem carbo. You know, there might be a lot of gem carbo.
There might not be.
Is there also a difference in the time since recurrence or time disease-free interval, I should say, between Impassion and 355?
There is.
So Impassion's a year.
Impassion's a year.
And this is 6 months.
This is 6 months, exactly.
That
So
would be
it might be a more resistant, high-risk population.
What's going to happen to the other Impassion trials? So, right, there's 132, which is the less than 12 months recurrence, getting gem carbo with or without atezo, right? And then there's the paclitaxel, the 131. What's going to happen to those trials when 355 announces? What are we going to do with that data?
Well, it's the co-PI for the adjuvant atezolizumab chemotherapy study. I can tell you that this is an active area of investigation and discussion.
Right.
A lot of discussion. I think generally, I don't want to speak for the other investigators, but I think generally speaking, the consensus is that we're a little reluctant to make massive changes to existing studies based on one study. And given that so much data is imminent in the next few months, that we have, at least for the time being, decided to hold the course, but come up with plan B, C, and D in case we need to pivot in a timely fashion when that additional data comes out.
You know, go ahead.
No, I was just saying, in terms of the PD-1, I think the data was very interesting at San Antonio. Do we know much about the stability of PD-1 over time? And does archival versus fresh specimen matter? Have they looked at those subsets as far as PFS is concerned in Impassion?
It seems to be similar between the primary and the metastasis. So that doesn't seem to be where they evaluate the tissue, whether it was early or later, doesn't seem to matter.
You don't have to be sure to get a metastatic if it's a difficult biopsy. You can feel pretty comfortable. You're not going to shortchange the patient if you use the primary.
Yes, although that being said, again, 40% of the patients had de novo disease. And so is that tissue going to be more like primary tissue? So I think there's still a lot more questions to answer.
Yeah, and for most patients, we'll have both anyway. We could take a look.
And it's only a 1% cutoff too. I mean, you know, so
1%,
it could be like 1%
of
in
immune
the primary archival and 2% in the med. I mean,
Right,
you know, it's such
right.
a low bar to kind of exceed.
Yeah,
So it probably won't be
which is
that big of a
amazing.
deal.
And it didn't make any difference if you were 1% or 1 to 5% or above 5%. You had the same benefit, right? Is that right?
They just showed
Yeah,
that.
they just showed that, right?
That's right. So that's, Alicia showed the Kaplan-Meier curves, which we hadn't seen previously for PFS and OS for the PD-L1 negative populations, because we were wondering, we knew that there was improvement in the intention to treat population, but how much of that improvement was weighed by the PD-L1 positive. So she did show the PD-L1 negative PFS and overall survival curves, and those lines are dead on top of each other.
Right, so you got to have, but only 1%.
1%.